Hi, I'm Betsy Nicoletti. I'm doing a brief video today on questions, and I'm going to give the answers about advanced care planning. I'm using these citations. So, of course, the CPT book professional edition this year. I'm recording this in April of 2025. We're still looking at CMS's frequently asked questions from 2016. It's not only still on their website, but when the OIG did their report about advanced care planning in 2022, they referenced that frequently asked question document. And then the MedLearn Matters article, which was updated in March of 2024, but really with no substantive changes from the original MLN article in 2016. So let's get started. Advanced care planning is represented, the service codes are two service codes, 99497 and an add-on code 99498. They're time-based codes. It includes the explanation and discussion of advanced directives, such as standard forms. Now here it says, with completion of such forms when performed, they are not required to be completed at the time of the advanced care planning. And the MedLearn Matters article states that in plain English. By the physician or other qualified healthcare professional, first 30 minutes, face-to-face with the patient, family member, or surrogate. When these codes came out in 2016, I think it was one of the first services that Medicare said, yes, you can perform this service without the patient present. Now, of course, you wouldn't do that unless there was a reason for that. The patient was unable to participate in the discussion. But it can be performed with the patient, family member, or surrogate. These are services to an individual, not in a group. And you say, where does it say you can't do it in a group? The code is not defined as a group service. And when there are group services in the CPT book, they're labeled as group. The ACP may be performed on the day of an office visit, an annual wellness visit, or other E&M service, and it can be done as a scheduled standalone visit. It may not be reported on the day of critical care services, either adult or pediatric. And if you say, where does it say that? You can go straight into the CPT book, and at the end it says, do not report with, and it lists those codes. It is a CPT tenet that you never double count the time or work from one reportable service to another reportable service. So you can't have spent a total of 30 minutes with the patient and bill an office visit in 30 minutes of ACP. You need the time that you're spending needs to be differentiated. And we'll see what the OIG said. Now, how do we tell time? Only in medical coding do we not tell time the way everyone else does. But here's the CPT time rule from the professional edition in 2025, page XX. So if you're watching this later, you're going to have to find that page. It may change in the 2026 book. A unit of time is attained when the midpoint is passed. For example, an hour is attained when 31 minutes have elapsed, more than midway between 0 and 60. And then the second hour is attained when a total of 91 minutes have elapsed. So how do we know that ACP uses the time rule? First, we go to the CPT book, and it doesn't say after the code, the full 30 minutes must be met. If we looked at prolonged services code 99417 or some care management or remote monitoring codes, after the codes, it would say the full 15 minutes must be met. Do not report for less than 15 minutes. Do not report for less than 20 minutes. And then in this case, the MLN Matters article referenced on slide 2 has a chart. And it says, of course, for less than 15 minutes, you don't report it. It's a 30-minute code. A unit of time is met when the midpoint is passed. So from 16 to 45 minutes, you report 99497. And if the visit goes from 46 to 74 minutes, you can report 99417 and one additional unit of 99498. And the chart goes on, but we get the point, right? The MedLearn Matters article says your documentation should include the fact that the visit was voluntary. An explanation of advanced directives. What does this mean? What are we going to talk about at this meeting? What is this? This is for a discussion about whether you want to be resuscitated, what kind of interventions you would want when you're no longer able to make that decision. So an explanation of that. Who was present? The time spent discussing advanced care planning during the face-to-face encounter. Any change in the patient's health status. Change in the patient's health status often triggers the discussion of advanced care planning. And the patient's healthcare wishes if they are unable to make their own decisions. The MLN Matters article says, report the condition of the diagnosis of the condition that you discuss with the patient. So if you had a patient with end-stage renal disease or with an advanced heart failure, that would be the condition that sparked the discussion, and you would use that condition. However, if you could have patients who want to come in and talk about advanced care planning because of something else that happened. They had a neighbor or a close friend, and they watched the decisions that were made at the end of life, and they want to make sure they get their wishes met. And so they ask to talk about advanced care planning. If it's part of an annual wellness visit, you can use an administrative exam or an exam diagnosis will support ACP. And the MedLearn Matter article says you don't need to report a specific diagnosis to bill for ACP services. So I get asked this question. I got asked it a lot in 2016, and it came up recently again. What about Incident 2? So first, let's review the rules for Incident 2 services. If you are a Coding Intel member, we have detailed information about Incident 2 on the website. But let's do the high-level review. We can perform Incident 2 services in a non-facility setting only, like place of service 11, office, not inpatient, not outpatient, not ED, in a non-facility setting. In order to bill a service Incident 2, the physician or non-physician practitioner must see the patient and initiate the plan of care. So we know that knocks off, we can't bill new patients Incident 2, we can't bill new problems Incident 2. And many consultants say, and some of your MACs will say, if you're changing the diagnosis, if you're changing the treatment plan, you can't bill Incident 2. That's not described in the Medicare manual, but again, look at your MACs to see what they say. Whoever's providing the Incident 2 service has to be an expense to the practice. The physician and NPP or NPP under whose NPI number we're reporting this Incident 2 must stay involved with the patient, and they or their same specialty partner must be in the suite of offices when the service is performed. So Medicare was asked specifically about Incident 2, and they addressed that in their frequently asked questions about advanced care planning on page 2. So again, the citation's up on slide 2. And here's what they say. The CPT code descriptors describe the services as furnished by physicians or other qualified healthcare professionals, which for Medicare purposes is consistent with allowing these codes to be billed by the physicians and NPPs whose scope of practice and Medicare benefit category includes the services described by these CPT codes, and who are authorized to independently bill Medicare for those services. Therefore, only those practitioners may report CPT codes. So you can't have a social worker reporting on their own with their own provider number, advanced care planning codes. That's not in their scope of practice. They go on to say, the ACP services described by these codes are primarily the providence of patients and physicians. Accordingly, we expect the billing physician or NPP to manage, participate, and meaningfully contribute to the provision of the services, in addition to providing a minimum of direct supervision. So when I read this, this is not a service. ACP is not a service where the physician or NPP sees the patient and says, you know, we should have you do an advanced care plan, an advanced directive. I'll have my social worker, I'll have my nurse come in and do that with you. That, to me, is not managing, participating, and meaningfully contributing to it. So no to the pastoral counselors doing it, sorry, no to pharmacists, no to social workers who are just doing it with that kind of a quick handoff. We're not going to do that. When I look at manage, participate, and meaningfully contribute, the example I would say you could use for incident 2. So here, this is my interpretation of what they say in the frequently asked questions from Medicare. The physician and the NPP or the NPP and the patient discuss the patient's wishes in the event the patient is unable to make decisions. That practitioner, physician, or NPP documents the discussion and the time personally spent in the discussion. Now, then maybe the patient says, I'd like to fill out those forms right now, or the physician or NPP says, you should fill out those forms right now. So the physician or the NPP asks the staff members to print out the right forms for their state and complete them with the patient. Don't count the staff member's time, only the physician or non-physician practitioner's time. Remember, when these codes were valued, they were valued with the work RVU that these services were going to be performed by the physician or non-physician practitioner. So what did the OIG find in their review? So they reviewed 691 ACP services, not a particular practice. They randomly selected them from Medicare claims over a 2-year period. Only 225, only a third of them complied with Medicare requirements. So what did the OIG say was missing? The provider didn't distinguish between the time spent in another service and the time spent in ACP. So they gave one example where the provider documents an office visit, collects the review of systems, documents an assessment and a plan, documents some ACP, and then says, I spent a total of 35 minutes with this patient today. But it doesn't distinguish how much of that was the office visit and how much of that was the ACP. So they did not allow that. And that was an example that they gave, and a fair percentage of the services where they said that the service documentation didn't comply with Medicare requirements was just that. The time specifically, exclusively spent in ACP wasn't documented. Sometimes the documentation didn't say that ACP occurred at all. Problematic. Sometimes no medical records were sent. So maybe for those, they looked and they say, oh, we didn't document it, so we're not going to send the records. 12 patients had advanced care planning billed 15 or more times in a 12-month period. Now, there is no Medicare frequency restriction on how often you can bill ACP. So let's say you had a patient who had an advanced care plan, they had an advanced directive, they've got it on their record. In your chart, they have copies of it at home. But perhaps something happened to a neighbor or a friend which has them nervous. Perhaps their own medical condition has deteriorated. Perhaps they've changed their mind about what they want to have happen when they're no longer able to make those decisions. And they want to change their advanced directive, and they have a discussion with their practitioner about that. So if the status changes, if the patient's wishes change, you can certainly bill advanced care planning more than once in a year period. But it seems unlikely we would be billing it more than 15 times in a year. And of course, the OIG didn't allow those. What else did they say? They referenced that frequently asked questions document from 2016, noting these are voluntary services and patients and their surrogates should be given a clear opportunity to decline to receive them. And if we go back up to slide 7, if you look at that, or just read the MedLearn Matters article, it says that we should be making it clear that this is a voluntary service. Appropriate documentation would include an account of the discussion that the service is voluntary. Patient agrees to talk about advanced directives. We don't have to make a big, huge template. Patient would like to talk about advanced care directives. Patient agrees this would be a good time to talk about advanced care directives. An account of what those are, who was present, and the time spent in ACP. They also point out this issue of never double counting time. When another service is performed concurrently with a time-based service, the time associated with the concurrent service should not be included in the time used for reporting the time-based service. So if you've done an annual wellness visit and advanced directive, worked on the advanced directive, had that discussion, you have to document the time only spent in ACP. Never double count the time or work or effort when reporting CPT codes that are, quote, not separately reported. Now, if you're a Coding Intel member, you know we've talked about ACP before since 2016. There are 2 articles. There's another video. So please take a look at those. And look, in addition to looking at our articles, read the source citations listed on slide 2. So, at Coding Intel, we really try and transform confusion to certainty. And I do apologize for my voice today. I think it's allergies or who knows what. Thanks for watching, and I look forward to speaking to you again for more of these brief videos.